Addiction treatment services have been integrated into primary care over the years in a number of ways. The most important way has been co-locating addiction treatment services in the primary care offices where primary care doctors see their patients. This has been very important, and it is where patients want to receive their addiction services. It has been very important both for the patients as well as for the doctors to be able to have informal as well as formal consultations with our clinicians. Another way has been with citing what we call behavioral health consultants, or BHCs, who are duly trained in both mental health and addiction treatment, evaluation and treatment in those primary care offices where our clinicians are not. So they're able to see patients in basically a walk-in type fashion when a primary care doc has a patient who has a mental health or addiction issue and is able to see them, and then has the ability to see them back on a scheduled basis. So that's been very important in having these patients' needs met. We do a fair amount of training with primary care folks as well to be able to keep them up to date. There have been very successful efforts in terms of using our technologies with our electronic medical record to incorporate screening instruments such as the audit to help primary care clinicians be able to screen their patients. That's another way we've incorporated it. We've been using the HEDIS score for alcohol and drug initiation engagement to increase awareness, and been able to use the money that has been made available for that to increase training and increase awareness in primary care. So those are some of the ways that we've been able to integrate addiction treatment. I would say the most important thing is co-locating services. The research has shown that's critical, and having the shared electronic medical record is also vital. So the primary care doctors, emergency room doctors can see in real time, right now, when they have the patient, what their patient has been dealing with and what therapies they may have received. There are confidentiality issues, and we protect those. And so the doctors have access to what they need to have access to for their patients, but we maintain confidentiality as well. We've done a fair amount of work with physicians in helping them manage patients with chronic pain. Our thinking about chronic pain has shifted quite a bit in terms of the use of opiates for chronic non-malignant pain. That is for patients who don't have cancer pain. And it seems that the pendulum is swinging away from the use of opiates long-term for other than cancer pain. What this has left us with is a lot of patients who are on daily opiate medicines, sometimes very high dose medicines, and the difficulty of patients discontinuing those, and physicians having conversations with patients about discontinuing or tapering. And of course, then the issue about, is this truly addiction? Not just physical dependence. Addiction is what we treat in this department. Addiction is a disease where your life begins to unravel. Physical dependence simply means that your body has become used to the medication, and when you stop it, you're going to have a withdrawal syndrome. Physical dependence is not an option for humans. If you're on this stuff long enough, you're going to have physical dependence and you will have withdrawal. Addiction, though, is a disease that shows up in a certain percentage of people, not most people, and that's what we treat here. So that becomes quite confusing for people and for doctors. We've done a fair amount of work in helping doctors to know how to have the discussion, have the conversation with the patient about the medication is not working, it's not working well, I don't see your function improving with this medication, In fact, the more we've increased the dose, I have seen your function worsen, and we need to look for other options to treat your pain, to manage your pain. Those conversations can be very difficult for doctors to have. I would say the most important key to having that conversation is staying within the medical role. We're medical people and we need to stay there. Oftentimes, patients may use language that tries to move us out of that role. So I mean by that, patients may say things such as, "Are you accusing me of being an addict?" Accuse is not a medical word. We don't accuse people of diabetes. We diagnose them with it. So we need to be very careful and listen to what people say. No, I'm not accusing you of anything. I'm trying to diagnose you. And so stay in that medical role. Are you labeling me a junkie? No, I have no interest in labels. I have interest in you being well. And I don't think this medication is helping you be well anymore. And I'm concerned about your safety. So safety is number one. Always remember that. And number two, stay in that medical role. Bad things happen when doctors leave that medical role. That's what they've hired you for. You are the medical expert. Stay in that role. The question of the overall efficacy of substance abuse treatment is a difficult one to ask. The thing we least like to hear is, what's your success rate? It's a very difficult question to answer because there is no specific quick answer to that, because it's a multifactorial disease, looks different in a lot of different people. What we do know is that of chronic illness in our country, diabetes, hypertension, asthma, addiction has the best track record. People need retreatment less with addiction. They have better compliance with their treatment plan. If we're going to treat those other conditions, and it's clear we are, we absolutely have to treat addiction. We know that if people are retained in treatment, if they're engaged at treatment at 90 days, that's a very good marker for success, for continued success in treating addiction. There are a lot of different factors that go into what we call success, and it simply is not abstinence, yes or no. Other diseases don't have that strict of a criteria about what success is. Addiction has been historically considered, are you drinking or using or not, and that's called success or failure. Diabetes doesn't have that same rigor, nor does hypertension. So we look more at, are things improving? Are you getting to work more often? Are you having more time with the family? Are things improving in these different spheres of life? And that's what we call improvement. We are, of course, heading for abstinence, because abstinence is how we can only 100% sure say the disease of alcoholism, the disease of heroin addiction is going to be taken care of. But we want more than just abstinence. We want people to define their lives by what it is full of, not by what it's missing. So I think that the next steps to help improve addiction treatment in our country, the number one has to be the expansion of medication-assisted treatment for opioid addiction. And I'm very hopeful that the expansion of Suboxone prescribing, buprenorphine prescribing will happen to nurse practitioners and physician assistants, and that the limits that are placed on physicians will disappear. It is inexplicable why these limits exist. It's the only medicine in our country that a limit exists. My nurse practitioners and PAs here at Addiction Medicine can prescribe opiates. They can prescribe it to as many patients as they care to, but they cannot prescribe Suboxone. I can prescribe opiates to as many patients as I care to, but I can only prescribe Suboxone to 100 patients. I tell patients this, I tell families this, I tell anyone this, and they say, that's insane, that makes no sense, that's stupid. They're correct, it is. And yet, here we are, still 15 years later after Suboxone was approved. We need to destigmatize this to help understand that this is a disease. People don't ask for this. Do they have a say in its development? Absolutely. Do people have a say in the development of cardiac disease, heart disease, lung disease, obesity, diabetes? Absolutely. So we can't single out people with addiction and say that their disease is somehow different. All diseases have an involuntary and a voluntary component, and addiction is no different from those others. So that's my great desire and hope for our country, that we would find a way to destigmatize this and finally get people the treatment they want. This is a nasty disease. It's painful, it hurts, and people deserve to feel better.